Good afternoon. We have come to the last session before our lunchtime. As you know, the previous sessions were very useful, and I'm sure it has made it easy task for our next speaker. Everyone knows the importance of diabetes and microvascular and macrovascular damages it creates. And kidney is not left alone. We know the expense. Dr. Jyoti has shown the expenditure that can concur on each patient. Who can afford to spend more than 15 to 20,000 per month for dialysis? So we had other drugs, ACE inhibitors, ARBs. We have thought that it is probably glomerular, probably due to hyperfiltration and metabolic injury that leads to diabetic nephropathy. But then we know now, other than glomerular disease, there is also tubular injury that is occurring. So we are still, we have not yet been successful in completely controlling kidney disease due to diabetes. So the next kid in the block is empagliflozin. It has been called as a game changer in Medscape. Is it so? To talk on this, we have none other than Dr. Krishna Seshadri, who has graduated from Madras Medical College. He has done his post-graduation in Chicago, Illinois Mason Medical Center, and also done his fellowship endocrinology in Chicago. He's currently working as Professor of Internal Medicine and Endocrinology, Diabetes and Metabolism at Sri Ramachandra University and head of the Department of Endocrinology and Diabetes. He is also the editorial board member of Indian Journal of Endocrinology and Metabolism. He is also executive committee member of the Endocrine Society of India. Sir, okay. I welcome you for this.
Thank you, ma'am. How much does a year do? I was here last year, and that slides from last year. And a lot of things have changed, including my affiliation and association. But my love for the Jyotidev family has not changed, so I'm back here to talk to you. I was thinking of doing a nice, simple beta cell talk, and then I got a call from Jyotidev saying, I want you to do this one. So here we go. These are all my masters, and each of them have a say in what I do. So I'm going to take off from where my mentor, Dr. Georgie Abraham, left off. I don't see Georgie around here, but remember that diabetes worldwide is the most important cause of end-stage renal disease. However, our options to prevent renal disease and diabetes are fairly limited. For some reason, we have always been fascinated with trying to use our existing oral hypoglycemic agents to prevent all the other stuff. I would love for my oral hypoglycemic agent to do just one thing: lower the glucose adequately and not cause complications. But that's not how the world works. Everybody is fascinated to see whether it prevents heart disease, whether it prevents lungs disease. I don't know what, but that's how it works. The role of the kidney itself in diabetes is something that we know for many, many years. We knew about glycosuria for probably a few thousand years. We knew about diabetes as being renal disease as being a complication of diabetes for the past 50, 60 years. But we never knew the role of the kidney in the pathogenesis of diabetes until about 10 to 12 years, when we actually discovered that gluconeogenesis from the kidney contributed a significant amount of this thing. I don't want to waste your time on SGLT2 inhibitors today because I'm sure you have a surfeit of this from the various talks you've heard. But remember that as we target this very, very unique set of molecules that work in the kidney, we have some fairly unexpected effects that have been very, very good for us. So let's take this, and I will start with the EMPA REG study and just tell you that I'm not very happy with this word EMPA REG Renal simply because it's not an independent study, but data that has been gleaned from the larger EMPA REG study, which is an amazingly good study, and you've heard a lot of stuff about it, and which pretty much showed that when you use empagliflozin in patients who are at high risk for heart disease, there was a non-inferiority and then a superiority of both cardiovascular as well as mortality outcomes. I could spend a day discussing the intricacies of the EMPA REG study, but my brief is to today talk about the EMPA REG Renal, so I will move directly there. When you look at the EMPA REG from a renal perspective, remember that there were 7,020 patients, 590 sites. The baseline GFR was about greater than 60 mils in more than 75%. Nephrologists in this audience will realize immediately that this is not an ordinary nephrology study where you would have patients mostly with lower eGFRs. The other kicker that you want to remember, and again this is different from your regular patients, is that 99% of these patients had established cardiovascular disease. So there was a double whammy going on. 80.7% were on ACE inhibitors or ARB. The issue here, of course, is for you to remember that we do not know, and this was never recorded in the study, because remember, this was not a renal design study, whether these patients were on maximal tolerable doses of ARB, which is a prerequisite for any renal study. At baseline, 28% had microalbuminuria and 11% had macroalbuminuria, and these were sort of excluded in the final analysis in some part, but not the whole part. We'll talk about it. A lot of the data that I have gotten is from the original NEJM article, but also some of the slides that you will see with lots of boxes are from the FDA Advisory Committee data. So I've tried to keep the data as genuine and this thing as possible, but it's always meant this thing. So when you look at the baseline characteristics from a renal perspective, you will find that this is fairly well matched. And remember though that this is not a classic renal study in the original context. So whenever you do a study, and as expensive as it may, and as much as we want a lot of data from it, remember that the role of a study is to usually address one question. And every other answer that you get out of that study can contribute to your knowledge, but can never be translated and said that this is a definitive piece of knowledge that you should use. So remember that whenever you look at any studies, whether it is a UKPDS, whether it's a Accord, whether it's a VADT or any other drug company moderated studies, whatever the drug rep comes and shows into you in terms of a piece of paper, the first question that you need to ask is this population similar to my population? The second is, what was the study really designed to this thing? Having said that, a lot of great information comes from studies that we can use but need to be confirmed in subsequent studies. So remember again and again when I talk about the study that the EMPA REG study was not designed initially to be a renal study. Though they had pre-specified renal endpoints, it was a cardiovascular study, and that is why the majority of patients who were in the study had previous cardiovascular illness. But having said that, they had a very pre-specified statistical plan. This plan was amended about 2 or 3 times, but this is what it was. Progression to macroalbuminuria, which is a good one that you want to look at. Doubling of serum creatinine with GFR less than 45, which is the gold standard for any renal study. But I will tell you the issues with this as we go on. Third, initiation of continuous renal replacement therapy, whether it is dialysis or transplantation. And something very interesting, they call it as death from renal disease, which is not found in major of studies. Remember that 11%, I'm sorry about this, had pre-existing macroalbuminuria, not macrovascular disease, and therefore excluded from the analysis. Now, some things were added at the end of the study. This is what is called a post-hoc analysis. And remember, generally, we don't look very favorably at post-hoc analysis, but this was an eGFR of less than 59. And also, they created a composite of doubling of serum creatinine, initial of renal replacement, and death from renal disease. Now, I'm just putting this piece of information to see, whenever you look at microalbuminuria or macroalbuminuria or any of the renal studies, you want to look at whether it was similar to studies that were done before, especially studies that showed a favorable outcome when in preventing renal disease. And the most important of them were the ARB studies. A very good study was the Renal study and the INDT study. And I'll show a comparison of these 3 studies in the end, and what these studies did show, and these looked fairly similar to that, except for the 1 or 2 points that I missed. One more point that I want to point out before we move on is to understand that it was something very simple, and one of my colleagues who's written about it, I'll tell you his comment. They used the MDRD formula at the time of initiation of study, but throughout the study they used a CKD epi formula, which is actually the correct formula to be used in patients who do not have pre-existing renal disease. So my friend said that you generally come home with a woman that you take out for dinner. So that's what he said. So what about the next thing that they said was, so they looked at, when you look at a composite of the pre-specified microvascular outcomes, you will find that they looked at these things. Whether there was initiation of retinal photocoagulation, vitreous hemorrhages, diabetes-related blindness, or incident and worsening nephropathy. And you will find out that the microvascular outcome was significantly better in the EMPA group. I'm not going to hash split here between 10 and 25. We will use, just trust me when I say that they were the same. But what is interesting is that the majority of the microvascular outcomes were driven by the benefit that was seen in the renal group. For example, and 38% of the reduction in microvascular outcomes were actually driven by the renal data. For example, if you look at this very, very carefully, and this is from the FDA's advisory board, you will find the composite microvascular thing was good. Whenever you read these tables, just look at this part. See if this part that is the upper end of the confidence interval. If it's more than 1, then you can ignore that data. It is not significant. And you will find that it is fairly significant. There's no new worsening nephropathy. But if you look at the eye disease, and this is true of any other study, you will find that there was not much benefit. You will find that it was not significant. Although the hazard ratio is 0.69, the upper limit crosses 1. And this is true of many of the studies, and it looks like retinopathy seems to be a different animal. Although we club microvascular disease as one big picture, it looks like nephropathy and retinopathy are two different animals. People who know, who studied it will tell you that there is PPAR alpha involved, a whole bunch of other stuff. This is looking at just a renal endpoint. So clearly, one of the things that we know is that this drug does not really work well in terms of preventing retinopathy. It may contribute, but we don't know much. In terms of renal endpoints, look at this. New onset albuminuria is the other part. That while the drug prevented progression from micro to macro, which is a major part of its effect, the prevention of normo to micro was not seen. Why was it not seen? Simply because the trial was not long enough. It was a 3-year-old trial. It takes years for people to progress from normo to microalbuminuria, and that could be the important reason. So new onset of macroalbuminuria was the most important outcome. Doubling of serum creatinine, though this looks very, very impressive in this trial, I'd like you to point out that there were issues with this. Second, the number of patients with this doubling of serum creatinine business itself was very low. So I don't know if you can make a large thing, but the nice thing to know is it prevents progression of micro to macroalbuminuria. And this death due to renal disease is another issue that we can talk about. So let's look at the first part. This is the incidence of worsening nephropathy. Clearly amazing piece of information. Hazard ratio 0.61, good confidence interval, excellent. This is a post-hoc composite renal outcome. It's good. I don't want to spend too much time on it because I'm not a big fan of post-hoc. So let's look at and these are my comments, so this is not data. So whatever I've put my view on, I've clearly indicated. So there's no new or worsening nephropathy driven by new onset macroalbuminuria. So the biggest thing is from micro to macro, big thing. 85% of these events were due to this. The one thing to remember, of course, is that this could be capturing small or reversible transient changes, but I think this data is real. Now, the one interesting thing was, and I'll show you this, is that when the drug was stopped, then measured later, there was no difference in my albuminuria between the two groups, which means that this is working through hemodynamic changes and not by necessarily affecting the primary pathological process. So clearly, what is happening is a hemodynamic process that this drug is creating, and I'll talk about this towards the end of my talk, that the hemodynamic process is contributing to the reduction in microalbuminuria, which means once you stop the drug, the effect goes down. Now, this is the doubling of serum creatinine, and if you look at this Kaplan-Meier curve, it looks exceptionally interesting, but this is not something I'm very happy with. Why was this? the thing is that when you look at the trials, if you look at a trial for doubling of serum creatinine, you need two things. One is you should show that this doubling of serum creatinine is in a chronic condition. Remember, serum creatinine can double also in acute, which means that you should not just measure one creatinine, you must be measuring serial creatinine to show that the doubling of serum creatinine was prevented. The study was not even designed to look at that carefully. They just added this, and so did not require confirmation of a specified time period to ensure that the decline in renal function was due to chronic failure. And when the FDA advisory committee actually looked at this and randomly picked up patients to see what was it, they thought that many of this was due to acute kidney injury or acute doubling of serum creatinine that was being prevented, and therefore they felt that this is not the biggest part of this whole thing. Similarly, continuous to renal replacement therapy is very interesting, but I want you to remember that this was not designed to capture progression to ESRD. Now, what about safety? I think there are a couple of safety issues that were interested. One is that when you look at early events and overall events, I think EMPA was very, very good. But one of the things that you must remember is that every drug like gliflozin and given, and that includes EMPA, and also their antihypertensive or ARBs or ACE inhibitors will reduce the GFR first. But when you and keep it there, and then over a period of time it remains constant. On the other hand, placebo, you will find a consistent decrease in GFR. When you stop the drug, the GFR goes back up, which is good, meaning it's reversible. The systolic blood pressure is lower, and I want you to know something very interesting about using gliflozins and renal failure. This is something absolutely fabulous. What happens is that irrespective of the GFR, the blood pressure remains a constant and reduces. At whatever GFR you give a gliflozin, the BP comes down. On the other hand, as the GFR decreases, the HbA1c effect comes down. For example, let's take any gliflozin. At an A1C of at a GFR of 90, the A1C reduction will be 0.6 or 0.8. At a GFR of 40, the A1C reduction will be only 0.3. At a GFR of 30, the A1C reduction would be same as placebo. So remember that the efficacy comes down. So let's looking at a closer look. It looks like this works very, very well. To sort of go towards the end of my talk, I want to talk about three things. One, how does this stack up with ACE inhibitor and ARB? And I've just put this data, and remember these are three different trials. Not very easy to compare, but if you look at this carefully, you will find that what you see is that this data is really amazing stuff. Would I use this to start tomorrow on all my patients to say that I'm going to use this to prevent nephropathy? No, I'd like to see another trial. But this data that is provided is actually really good stuff, despite all the problems I've talked about. What seems to be happening? I think what is happening is this is an effect that we are familiar with, that when you give an ACE inhibitor or an ARB, the blood pressure comes down. There the efferent arteriole is affected, and therefore what happens is that the interglomerular pressure comes down. But the opposite happens with an SGLT2 inhibitor. When you give an SGLT2 inhibitor, I'm sorry about the animation, sorry. And therefore, what happens is, instead of the efferent arteriole being affected, the afferent arteriole, the afferent arteriole gets affected and gets vasomodulated. So what you're really happening is, if you give an ARB, the efferent arteriole dilatation occurs. When you give an SGLT2, the same change occurs in the afferent arteriole. The glomerular pressure normalizes, and therefore less renal injury occurs. Of course, we need long-term data to support it. In animals, and in rat models, you know that this is true. That mesangial proliferation comes down, apoptosis comes down, and renal improvements occur. So, this is just looking at glomerular filtration in EMPA versus an ACE inhibitor. This is again rat data, but you will find that that these seem to be fairly similar. Now, why is there any other reason that's happening? This is something very interesting that was presented by one of my colleagues, Sundar Mudaliar, in the recent ADA. And he used something very interesting. Remember that all SGLT2 inhibitors have an increased risk of euglycemic ketosis, right? And one of the things that happens with it is there's an increased amount of beta hydroxybutyrate that is present. What Sundar and his colleagues said was that the same ketones that we think are bad can actually be used by an injured heart or a kidney for another reason. Why? Because although although the calories that come out of each of these are the same, the energy liberated by a beta hydroxybutyrate, which is a ketone body, is much, much higher. So in situations of hypoxia or illnesses, these beta hydroxybutyrate become a very, very preferential substrate for the heart and the kidney. So which means that when beta hydroxybutyrate is present, the heart can function far more efficiently. When beta hydroxybutyrate is present, the kidney can function far more efficiently. Remember, if there's no insulin, then this becomes a problem. In the presence of insulin, this becomes an additional benefit for the heart and the kidney. Again, remember, this is a hypothesis, but very interesting. So when you use a fuel that has the same caloric intake, but releases a lot more energy, you actually get a benefit. And this is just a hypothesis. They think that this is one of the reasons, not all the reasons, why these drugs probably work and improve renal function as well as in this thing. Of course, you need good mechanistic studies to support it. So many companies now are salivating at the fact that you'll start using both an SGLT2 inhibitor and a RAS blockade at the starting of diabetes. Is it a dream? Probably not. I think the data is moving towards a direction where the data is factually supporting it. Having said that, a swallow summer does not make. And especially when it comes to additional benefit when you see with drugs, other than what they're intended for, it is important that we ask for more burden of proof. Simply because when you start a drug for a long-term period of time, other than for a reason that it's primarily intended, then there should be a really higher burden of proof. If somebody says this drug is superior, then I would say show me a superiority study that is designed carefully. This is a subgroup analysis of a larger trial. Pre-specified, good data, large number of patients. I'm very, very happy to see this results. But I'd like to see this data again in patients who do not have cardiovascular disease. The normal diabetic population that you and I see. Such a study may never get done, but this is very, very interesting stuff. It gives me one more reason to start using SGLT2 inhibitors, especially in my high-risk population. So this is the overall. I'm sorry if I'm muddling the waters by giving all these caveats, but I think we should never get exuberant about anything, especially with trial data where statisticians probably decide what we end up consuming. So the primary outcome of EMPA REG was that it was beneficial in terms of it was safe in cardiovascular outcomes and possibly beneficial with possible mortality benefit. Remember, down. And in the renal component of the study, where 11% of the patients were excluded and then looked at, there was a decreased progression of microalbuminuria from microalbuminuria to macroalbuminuria. Not much change in normo to micro, but overall renal outcomes of incipient nephropathy, which is predominantly determined by micro to macro, was beneficial. This is good news. It tells us that these drugs are not harmful to the kidney and they may actually be beneficial. What would I like to see? More studies, which means I can come and do one more talk in Trivandrum sometime later. So thank you for your patience. I could see people just wafting to the sense of lunch. I'm grateful to the people who actually thought listening to this stupid talk was better than going immediately to lunch. Thank you so much.
Thank you, Dr. Seshadri. I think it's a new drug. Everyone is still skeptical about it. We are still not sure. We know definitely it has some effect on the cardiovascular system. Maybe the outcome may be good for them, and the ketones and all that play an important role for energy. But then if you say microalbuminuria to macroalbuminuria, mortality, actually the risk for death increases from 4.5% to 6%. So maybe, we don't know. Then I'm a little concerned. What about those patients with autonomic neuropathy? Diabetic patients will be having autonomic neuropathy. They can have low intravascular volume. On top of it, having the neuropathy can have giddiness and other complications. Then we as nephrologists are concerned, though you may say the patient has acute kidney injury and he'll recover and it is reversible, but it can cause some damage to the whatever residual renal function is there. So we are also concerned. We as nephrologists are wary about it. We are not yet sure. What are your comments?
Well, I think autonomic neuropathy is a piece that most of us have not figured out. I don't know if people are aware of it, that if you have established autonomic neuropathy and there are a bunch of tests to look at it, that your mortality, your 5-year mortality is 50%. This is some piece of data that most people don't even talk about. But your 5-year mortality, if you have autonomic neuropathy, is 50%. So you're trying to get more information added onto a disease that is already very, very highly dangerous. And remember that, diabetologists don't think about AKI as an important component of this whole thing. But any drug, including ACE inhibitors and ARBs, can cause AKI in the initial phases of starting. Yes. The good news is that after that initial phase, that the risk of AKI actually comes down with all of these drugs. But any of these drugs, especially in combination with NSAIDs, can do AKI.
So the message is we have a new drug, we can try it, and we should be cautious before we jump in delivering it to all the patients. So these...
I'm not the person who's... unfortunately, I'm an old-fashioned doctor. I'm not the first person to start a new drug, and I'm certainly not the last person to give up an old drug.
Nephropathy, microvascular. What about peripheral neuropathy?
No, not measured in these studies, but remember, those are also probably, we need to look at some of these. These studies were not designed, but I can give you some example from the VADT trial. Even in the VADT trial, a lot of us talk about cardiovascular disease as the one that doesn't change with tight control in long-standing diabetes. This is true of microvascular disease also. For example, in the VADT trial, there was no improvement in renal outcomes. There was no improvement in retinal outcomes. So, yes, it's nice to teach medical students that microvascular disease are nephropathy, retinopathy, and neuropathy, but there are subtle variations and differences, and our traditional paradigms of glucose control probably do not apply anymore in this. We need to get more data.
So the other thing is, you said the duration was not long enough for normal to micro.
Correct.
But it is the same duration which has shown that micro has not progressed to macro.
But remember, there is a curve in the progression of disease. Micro to macro happens much faster. Once a disease process is established, its rate of progression is much different from the establishment of the disease process. So you can have a long, subaltern, slow progression from normo to micro, and a rapid progression to micro to macro and macro to ESRD. So that can occur. So that is the natural history of the disease, and that is influenced by other variables.
Other thing, on stopping the drug, we have found that the renal function further improves. On stoppage of the drug, we have found that the renal function further improves.
Correct, but
with
the question is,
what is the reason?
But the question is, do you want it? Because
what is the reason?
Which
is
one? It's just a hemodynamic effect. The renal function does not improve. I'm sorry.
Hyperventilation may be there.
No. I think we need to. Give me a minute to explain. Once you start any drug, including an ACE inhibitor, the GFR will drop, and that is because the interglomerular pressure comes down. So, and the GFR will remain lower for the duration of taking this thing. It will drop acutely, it will climb back, and it will reach a plateau, but it will never reach normal till the drug is stopped. The moment the drug is stopped, the interglomerular pressure is restored. When that happens, the GFR will go up. But you don't want the GFR, and Madam can expand, when you want to prevent renal disease, you don't want the GFR to go up, because if it goes up, what's going to happen is it's going to keep banging the nephrons, the podocytes are going to be destroyed, periglomerular fibrosis is going to occur, and the creatinine is going to go up. So you want to keep this GFR a little lower, and that's really what we are achieving by either an ACE, ARB, EMPA, or a combination. Ma'am, you want to expand?
This rise in creatinine is expected. About 10 to 20% is expected. If the rise in creatinine is seen to be more than 30%, we have to stop the drug. We should not continue with the drug. And also you have to be careful about hyperkalemia. So you tell the patient when you start this drug, within 2 weeks to come and check the creatinine again, and after 2 months again. If the creatinine remains stable, you may continue with the drug. But if there is a trend for rising creatinine, you have to hold the drug when you start an ACE.
It goes back up. That's because this was not a permanent effect, it was a temporary effect. You stopped it, it went back up.
Just
The effect was being maintained by the drug. Hi.
Yeah.
Johnny.
Good, excellent talk. Just want to clarify whether I understood you right. That is, in cases where the EGFR comes down below 30, the effect of HbA1c is not there. But will the effect of EMPA REG renal outcome be continued?
We don't know because remember that most of these patients had higher GFRs. You should really look at a study where the EGFR is much lower.
It's not given for those with GFR less than 45. And
so will that, even though the HbA1c benefit is not there, will the renal benefit be continued?
Correct. The FDA Advisory Council said no can do. In fact, they said that no, at this point of time, we do not have the data that is sufficient for us to say, and this is the EMAC Advisory Board, that said data that is sufficient for us to say that we should revise the label for use at a lower level. So which means that they were not convinced. Having said that, they also said that they gave it a little pat on the back and said that this drug probably, that the effects of that there are some probable effects that may be beneficial. So they were iffy and washy, but they did not go out the distance and remove the package and such. So clearly they probably also feel that the data is lacking.
I think it's lunchtime, and thank you, Dr. Seshadri.
Thank you.